The procedure, in essence, will start with hydrodissection, which is critically important to open the perirectal space with saline, obviously, and make sure that the needle is properly placed and the space is opening before the SpaceOAR injection actually happens. Hydrodissection is a security step of the procedure, so that if the space doesn't open adequately or doesn't open in a patient that has some scarring, for example, then one should not proceed. Once you have proper hydrodissection and opening of the space, you can proceed. That's why we do it. It's to confirm opening, confirm symmetry, proper needle, safe needle positioning, and visualizing the anatomy where the SpaceOAR will be injected. During hydrodissection, one of the things to confirm proper opening of the space, rather than having the needle in the rectal wall, is to see that there is a dark signal, which is water-like ultrasound signal, that opens and opens that space. So if that water-like dark signal is visible on ultrasound and is visually pushing the rectal wall away as opposed to permeating it, then we know we have the needle in the proper space. Now, what we don't want to see is once you're hydrodissecting, the needle is basically not distinct from the rectal wall. So it could be in the rectal wall, and the saline could be permeating the rectal wall. So you would not see a dark signal, but like a grayish that is permeating the rectal wall. And at that point, the needle needs to be adjusted so that you don't continue the process if the needle is too posterior. One of the aspects that is part of the learning process for physicians as they start and they get better and better at this procedure is to gauge the resistance to the injection or to the plunger once you're doing hydrodissection and what's causing that. So the simple way to understand this is if you're trying to inject saline into a scar, it's going to feel like there's a lot of resistance. So you should, when we're talking about patients that have HIFU, cryo, and so on, expect that there's going to be some scar, there's going to be increased resistance, and a normal hydrodissection would not have a lot of resistance at all. Rather, it would not have resistance and the space would open. So that's what you're hoping for. When you have a lot of resistance, that is usually scar, or the needle may be in the wrong position. Maybe it's in the fascia or in the rectal wall. So you have to look at your anatomy carefully, maybe consider repositioning the needle. Ask yourself, is this due to a scar? Do I see scar tissue? Did the patient have history of procedures that could have caused this? So you need to review the medical history in advance and think of the different things that could affect the procedure as you do it. One of the ways you can see that is if you begin your hydrodissection and the space does not seem to open like a black dark signal, but it's a gray signal that permeates down into the rectal wall. The other is when you go to axial view, move the probe back towards the point where the tip of the needle is visible, the very, very tip of the needle. And then you gently wiggle the needle only anterior to posterior by about 2 millimeters. And you can see the needle sometimes dragging the rectal wall layers with it. But this is a very gentle anterior to posterior only. You don't do it left to right, sideways. And if you see that dragging the rectal wall layers anteriorly, dragging it with the needle tip, then you know you have to reposition the needle. Now, the needle may have penetrated the rectal wall layers at the apex, at the entrance. So again, you may not see that or have that, be able to detect that on axial view, because it happened much lower at the entrance, at the apex level. So you need to avoid the rectal wall coming in. Don't transect the rectal wall. Once we complete hydrodissection, one of the key steps that cannot be missed is to actually aspirate to make sure that the tip of the needle is not in a vascular space, which is something extremely rare, but it could happen.